Now let's conclude this module by talking a little bit about discharge planning and summarizing what we've discussed so far. So in order to successfully discharge a patient, we need to think about some of the barriers to discharge. As you might imagine, for a patient who is a newly diagnosed diabetic or someone that's just starting insulin, we need to emphasize communication and patient education. It's very important that they have an understanding of the cost of the medications, that they understand carbohydrate-rich foods, and what to do when they're hypoglycemic or hyperglycemic. As a medical student, you have a unique ability to help counsel the patient on these things. You have more time and the know-how to sit with a patient and really go through their medications to make sure they understand them. As you might imagine, things that help reduce readmission and reduce errors would be really good communication between both the patient and their outpatient provider. It's also important that we try to involve the diabetes educator, nurses, pharmacists, anyone to make sure that the patient understands their new regimen. A good strategy for doing this is using something like the teach-back method, in which you ask the patient to speak back to you or teach back to you the information about their insulin regimen that you have discussed with them. Let's briefly review some of the reasons that a patient might be hyperglycemic or hypoglycemic in the hospital. In terms of hyperglycemia, some things we talked about: stress-induced hyperglycemia, actual medical errors, changes with diet or snacking during the day. Patients sometimes have a fear of hypoglycemia, or if it's something we're doing, like giving them steroids. In terms of hypoglycemic influences, again, we have this unpredictable PO intake, a patient who might be newly NPO but still getting full dose insulin, a patient who is having a lot of nausea and vomiting or GI illness, again, medication errors, problems with clearing the insulin, i.e. if a patient has significant kidney disease, and then finally, altered cognition, so that it's difficult to appreciate if they have acute changes that might be consistent with hypoglycemia. Finally, to summarize Mr. Brimley's care, we worked on calculating a weight-based total daily insulin requirement using his weight times his insulin category to create the total daily insulin requirement, which we then divided into basal bolus and a slide. We talked about managing glucocorticoid-induced hyperglycemia using prednisone dosage into our formula to calculate how much NPH should be dosed with the steroids. And finally, we discussed ways to recognize and treat glycemic emergencies: hyperglycemia, making sure we're treating with fluids, insulin, and potassium, and hypoglycemia, where we're either giving oral complex carbohydrates or IV dextrose. Mr. Brimley is very happy with your care, and he's safely discharged from the hospital. Take a moment now to review any parts of these modules that are confusing. What will follow is a quiz that will involve doing some simple calculations similar to the ones that we did in the earlier module sets.